male with a classical complaint of nasal blockage and occasional bleeding.
Mm-hmm.
Young male patient with such complaints on endoscopy, some mass in the nasal cavity behind gives you a suspicion of juvenile nasopharyngeal angiofibroma.
Right.
That's how it is clinically suspected. Since once you suspect an angiofibroma, which has a high propensity to bleed, we avoid routinely taking a biopsy. So
Yes.
what next is the radiology to substantiate our diagnosis on basis of certain clinical extensions of angiofibroma. It has a, you know, some preferential extensions from where it arises, which gives you a classical picture of JNA with huge contrast enhancements and flow voids, making it a vascular tumor. So that is how. So this is a coronal contrast imaging to give you an overview. This tumor, see, that's the pterygoid process.
Yes.
From the anterior surface of the pterygoid, that's the center from where it arises. Can you see the center area?
Yeah. Yeah.
Just, at the face of the pterygoid. And then it has a classical extensions all around. All around means this pterygopalatine fossa is like a crossroads from where this tumor invades the pterygoid bone. It
Yes.
comes in the posterior part of the nasal cavity, and from there it goes in the nasopharynx. From this pterygoid base, it goes to the sphenoid sinus by eroding the floor of the sphenoid sinus. It
Yeah.
doesn't enter the sphenoid through the natural ostium. Then, from the pterygopalatine fossa, it goes up into the inferior orbital fissure. If I follow it, that's the superior orbital fissure. And if I follow it behind, that's the cavernous sinus. Superior orbital fissure is a continuation of anterior continuation of cavernous sinus. Let me show in the axial plane like this. See this? That is the superior orbital fissure. See the orbital apex there?
Yes.
And from it is extending towards the carotid in the cavernous sinus. So that is another preferential extension.
Mm-hmm.
Then because it comes in the pterygopalatine fossa, it easily prolapses through the pterygomaxillary fissure laterally into the infratemporal fossa,
Right.
which is a potential space containing couple of muscles, neurovascular structures, and it has the ability to accommodate even large tumors by means of expanding and compressing the surrounding structures. And see where the tumor has gone far deep, even beyond, see that is the mandible behind. Even behind,
Yeah.
anterior to the face of the mandible, going far laterally and far inferiorly down.
Yeah.
See the huge, like a cricket ball again, prolapsing into the infratemporal fossa. Now, if you take the level, that's the level of the hard palate. See, that's
Yeah.
the level of the hard palate. The tumor is going even 2 centimeter, almost 2 centimeter below the level of the hard palate. Can you see?
Yes. Yes.
That is how this tumor is prolapsing this way. So this is another preferential extension. And see from here, from the pterygoid, it goes down in the pterygoid fossa. That's the entire pterygoid fossa which is involved by the tumor itself. So, tumor in the posterior part of the nasal cavity prolapsing toward nasopharynx, sphenoid sinus, inferior orbital fissure, superior orbital fissure, cavernous sinus, in the pterygoid fossa, in the infratemporal fossa, and far laterally even into the cheek. So these are, see, classical extensions laterally. This is anterolateral and this
Yeah.
is posterolateral. That is, here is the pterygoid process, invading the pterygoid process here. See this pterygoid process?
Yeah.
And then going far laterally and behind the pterygoids into the deep part of the infratemporal fossa. That's how it goes down in the parapharyngeal space. Day before we demonstrated the huge one going in the parapharyngeal space and the temporal lobe. So these are the classical extensions of this tumor. Now, from surgical, point of view, there are lots of information you expect from radiology. And more radiological information make surgical life more easier. Now, what all information required from the radiology to make your life easier? Number one, see this is T2 weighted fat suppress imaging.
Yes.
One of the reasons why these JNAs tend to recur, the so-called recurrence. This is a benign tumor like any other benign tumor in the body. If completely removed, there is no question of recurrence. Even if a millimetric part of the tumor is left behind somewhere, it is bound to regrow and then present as a recurrence, so-called recurrence, much difficult to remove. As the vascularity now is all unpredictable, it becomes more invasive. That's why the endoscopy has scored over the open approaches, because you have seen this tumor. This grows into various, foramen, fissures, crevices everywhere. Endoscopy gives you ultimate visualization, magnification, right on the point. You can go with the telescope and see carefully and remove it under vision, which is not possible with the open approach. We have seen traditionally open approach, you try to remove the tumor, it bleeds like anything, and ultimately you pack and come out. And you have no opportunity to inspect each and every foramen and fissure and narrow areas where the tumor might have left behind. That's how endoscopy definitely has an edge over the open approach. It's not like we are avoiding an incision, which gives us a better approach. If any approach, even with a bigger incision, gives better outcome, I'll opt for that. We are not biased toward endoscopy or pushing every case for the endoscopy like that. So, another information. So, why this tumor tend to recur most often? Because it is left behind in the cancellous bone, of sphenoid and its processes, like pterygoids, greater wing of sphenoid. If this tumor infiltrates the clivus, pterygoid, or any Haversian system of the bone, which may look obviously from the outside, visualization looks intact, but the tumor might have penetrated inside, which can be seen based on radiology. And if it is, you can remove that, drill away that bone to prevent recurrence. So that's how we need some information from the radiology. And this is what the sequence T2 weighted fat suppress. Why fat suppress? Because all this bone contains marrow. Marrow contains fat, and fat brightens on T2 weighted imaging. If you suppress the fat, and anything then after suppressing the fat brightens the marrow area, has to be tumor. And this is what you can see. See this carefully on T2 weighted imaging. This is contrast. This is the tumor in the pterygoid process. See the tumor, hyper intense signal in the pterygoid process. Look at the normal pterygoid on the opposite side. It has a marrow, it brightens, but it is not brightening up because the fat is suppressed. If we take a regular, let me bring on a regular T2 weighted imaging. This is regular T2 weighted imaging. See now, regular T2 weighted imaging, even the opposite side marrow is enhancing.
Yes.
You cannot differentiate from a tumor. In T2 weighted fat suppress, the fat is suppressed, and now nothing is enhancing, means there is no tumor. What an amazing sequence, by means of which you can pick up any marrow infiltration in the surrounding, which needs to be thoroughly excentrated to prevent so-called recurrence. This is of utmost utility, I would say, this kind of information. Second information, what you expect from the radiology, when it goes, intracranial, you need to have a clear demarcation whether it is invading the intracranial structures. Maybe, see this. This T2 weighted imaging showing the clear demarcation of the dura, everywhere, which is not appreciated on any other sequence like this. So here, even this tumor has a propensity to grow circumferentially from the area of origin and compressing all around. It is not generally invasive. The revisions can be invasive. We have seen the revisions, where the, unpredictable vascularity becoming more invading the dura, invading the brain tissue, truly invading the brain tissue, we have seen. But the primary tumors generally do not invade, and they grow by compression, not by invasion. So see, The interface with the surrounding is very clear. Can you see?
Yep.
See this tumor going in the orbital fissure, but all around, can you see the periosteal plane intact?
Yeah, yeah.
That gives a useful information that it is not invasive. Number 3, as it is going in the cavernous sinus behind, how to get to know whether the carotid is invaded or not? That's a very vital information. Otherwise, it always gives an apprehension to the surgeon. See this tumor from the inferior orbital fissure, superior orbital fissure. Now, that's the cavernous carotid.
Yes.
On contrast, enhancing like invading the carotid artery. Can you see this? But
Yeah.
it is not truly invading. I said this tumor grows and compresses the surrounding structure rather than invading. And see this. Let me bring all the 3 sequences together to give you a clear picture whether it is invading or not. This is axial, and this is here the sagittal. Now the first axial. See this axial. And then I will bring the 4th one to give you a clear picture whether there is a carotid periosteum intact or invading. See now, on the axial. See, this is the petrous carotid artery where my cursor is. Can you see?
Yeah.
This is petrous carotid. Now going up, now I am going up. This is the horizontal petrous carotid. Very clear?
Yeah.
This is the horizontal petrous carotid. And this tumor coming from the orbital fissure. See this? This is the entire superior orbital fissure which is involved by the tumor. And from here anteriorly going through the superior orbital fissure, growing towards the cavernous sinus. That's the cavernous carotid. That's the cavernous carotid. And there is the, see this, periosteum all around the tumor. Periosteum all around the tumor, which is giving you clear picture that there is a thin periosteum all around the tumor, separating from the
Carotid.
tumor itself. Can you see very clear or not? Let me change the window intensity to show you. Can you see the thin periosteum around the tumor?
Yes, yes.
Black line.
Yeah.
No, see, that is the periosteum that is giving you a classical picture that tumor. See the black line,
Yeah.
giving you clear picture that the tumor is not invading. This information can be elaborated better on angiogram. So we have an MR angiogram. MR angiogram is non-invasive. See this, the same carotid artery.
Yeah.
Can you see the same carotid? The foramen lacerum carotid, the petrous carotid, and see this is the tumor which is coming behind.
Right.
That's the tumor, and see this carotid is distinctly separated from the tumor. See this. Tumor is not infiltrating, not giving any irregularity on the carotid wall. Can you see
Yes.
the smooth carotid lumen and distinction of tumor giving any irregularity? Can you see some vessel arising and going back into the orbit?
Right.
That
Yes,
is
yes.
ophthalmic artery. Hello?
Yes, yes. Go ahead, Satish.
This is ophthalmic artery.
Yeah.
This is the retrograde branch from the first part of the carotid, which is going into the orbit. You can see very clear. And that's the cavernous carotid. So the
Yes.
tumor is coming onto the carotid, but not invading. Now, another important thing, what you expect from the radiology is the angiographic study. See this. What we want to know from this study, this is the cavernous carotid dividing into anterior cerebral and the middle cerebral. And these anterior cerebral joining to form the ACOM. That is anterior communicating. Behind is the posterior cerebral. And from here, this is the posterior communicating artery. That's the posterior communicating.
Yes.
Joining both the circulation to complete the circle of Willis. That's the posterior communicating.
Yeah.
The cross flow at the level of the brain can be seen well on the angiographic study. This is very important when you deal with the tumors around the carotid artery. Third important information from the angiogram. See, we know the principal vessel invading or supplying this tumor is this internal maxillary. How to follow this and how the vessel is entering? See, this is your external carotid. internal carotid here, external carotid here.
Yeah.
Follow my cursor. External carotid going behind the mandible. This is mandible.
Yeah.
And here it is see here it is dividing into two vessels. This outside going is the superficial temporal. And this one going in the maxillary.
Yeah.
See the maxillary artery.
Yes.
And see, I am following this maxillary where my cursor is. Follow this maxillary artery. Follow this maxillary artery all the way. See this maxillary?
Yeah. Yes. Yes.
See where it is coming. Can you see?
Yes. Yes.
That's the maxillary sinus. And this is coming just behind the maxillary sinus in the anterior most part of the pterygopalatine fossa. Can you see very well? Look at the maxillary sinus on this side and see with tumor expansion behind what has happened to the maxillary sinus. It has pushed the posterior wall of the maxillary sinus anteriorly. Classical Hallman-Miller sign. See, and in this anterior most part of the tumor, just behind the posterior wall, is the internal maxillary. That is where that is the basis of endoscopic excision, where you come by the Denker's approach from here directly onto it, open up the posterior wall periosteum behind the maxilla and catch the vessel first to devascularize to a certain extent. Now, this is the principal vessel, and see how much branching it is giving in this tumor to make it so vascular. See this? So
Yeah.
that's the principal vessel which you have to catch over here. Now, if I do a 3D reconstruction at this level, let me show you. This is the vessel if I catch. That is the vessel. That is, oh. That is the internal maxillary network. And see,
Yeah.
this is the maxillary artery. Can you see the maxillary artery here?
Yes.
This is the level of the palate. Again, this is very important sometimes, otherwise it is so difficult to find the maxillary artery. My level of the maxillary artery here from the hard palate is more than 2.8 centimeter. Can you see?
Yeah.
So once I open the posterior wall, I have to look for the maxillary higher up. Sometimes it is pushed inferiorly, sometimes it is higher up. And you really need to look at the vessel to devascularize the tumor. And it gives you such a great confidence where your artery is going to be. Can you see?
Yes. Yes.
That is the maxillary artery, with the principal artery giving ramifications into the tumor to supply it all over. So that's how it makes your principle of endoscopic surgery. First, go behind and devascularize this tumor by taking this vessel, clamping this vessel, clipping this vessel, and then you can bring out this tumor. At no point of time you are supposed to go inside the tumor. No point of time. So our goal in this case, our plan is very simple. That's a huge lateral extension. Can you see this?
Yes.
So what we are going to do, the nasal space is occupied by this tumor. So what we'll do, we'll go behind and catch this vessel first, number one.
Yeah.
And then we will divide, this is the level of the lateral wall of the maxilla here.
Yeah.
We'll divide the tumor here at the lateral wall. We will remove the medial part of the tumor first, this entire medial part, to accommodate later this entire lateral part coming into the nasal cavity. Otherwise, if you don't remove this medial part, you cannot bring in the lateral part, as there is no space in the nasal cavity to accommodate that. So the principle, the planning is very clear. We need to have a good exposure. I'll take a good far lateral exposure. See, this is my lateral wall of the maxilla, nasal cavity. And what I'll do to catch here, I will remove this much of the bone here. This much of the anterolateral wall to give me full exposure of this region. This part I can pull out later on.
Yeah.
Okay? So this exposure will allow me the opportunity to take this vessel over here. So I really need to remove this much of the lateral nasal wall to go wide laterally to have a full exposure of the posterior lateral wall, catch the vessel first, Then we'll divide the tumor here. The medial part will remove first, and then lateral part will bring in and remove completely. So the
Excellent.
plan is wherever the tumor is extending all around, same way we have to pull it from everywhere. It is pushing borders everywhere, pushing borders towards the muscles in the infratemporal fossa, towards the orbital fissure, towards the cavernous sinus. Everywhere is pushing. So we have to remove. We have to completely remove the pterygoid on this side, and this tumor is completely infiltrating the pterygoid from top to bottom. See this pterygoid from bottom to top, completely infiltrated by the tumor here. That has to go completely. We will drill away and remove this tumor. And the part of the tumor little bit which is projecting in the sphenoid sinus after eroding the pterygoid, we will see by exposing the sphenoid sinus and pulling it down. So this is how our planning is very clear, and the radiology has enabled us to plan everything. That's why in JNA we have to order adequate imaging. If you order just MRI, PNS, the radiologists are not going to give you more than 1 or 2 sequences and finish off in 10 minutes. Because in MRI, each and every sequence has to be shot separately. This kind of MRI, what we order, takes almost 1.5 hours. That's why it costs money as well, but it gives us complete information what you can expect and make your surgical life easier, and you can do a better surgical work than rather going blindly and coming up with surprises intraoperatively. Any questions, sir, before we go ahead?
No, you have explained excellent way. The term recurrence probably should be replaced by residual tumor. As far
it's
as
always
the
residual
diagnosis,
which regrows. Yes.
because
Residual which regrows, and the commonest reason of being residual is going blindly without adequate radiology,
right,
going without taking the vessels in control, with too much of bleeding and you are working blindly. And number 3 is the most common cause of residual is invading the Haversian system of this cancellous bone of the sphenoids and in processes and the clivus. So wherever on radiology, take titubated fat suppress, wherever is enhancement considering as a micro infiltration, you must radically remove that bone, because this is a benign tumor. If you remove completely, it is never going to come back.
I think, Satish, the part of the bone you explained, probably that is one which is missed by most. And usually,
If I don't have this radiology, even I would definitely miss.
Right. And post-op, I think, say after a week or so, or what is your protocol to repeat an MRI, all the sequences to confirm that nothing is left out? Do you go for a post-op radiology?
Yeah, that's a very important question. See, the biggest advantage of modified Denkers is it gives you a lifetime opportunity of surveillance endoscopically, even in your office, in your OPD. So, with this kind of pre-op radiology, knowing what bone is involved, and intraoperatively, you execute properly by removing that particular bone completely, ensuring intraoperatively under endoscopic visualization. With the Denkers access in the post-operative follow-up, generally you don't need any radiology.
Right. That is one point which is very important. You explained earlier also, and that is what I wanted to emphasize. Don't always jump onto a post-op radiology if you can visualize properly. Because the second question arises, patient will say it is a recurrence, or it is a residual which you left during the first surgery. So how to convince him?
See, this is a vascular tumor. Your visualization is always a challenge.
Yes.
Taking vessels into control is as a challenge. And this tumor has a propensity to invade narrow spaces.
Right.
So there is always a possibility of leaving behind it. All your expertise, your radiological information, everything matters.
Right.
So you have to, in any given situation, this is quite a complex situation. Even in the simplest, you have to convince to always keep a possibility of a second look, need of, revising something, revising some complication, whatever. So you always have to keep in mind, informing your patients accordingly. You cannot guarantee anything in science.
Right.
But
That's
this
very
kind of,
important point. Basically, nobody can say that my cases will not recur,
yeah.
however expert he or she may be.
See, with this kind of radiology
Yep.
and executing it properly, we will discuss during live surgery, each and every step.
Mhm.
You will see the advantage of radiology giving you visualization to each and every nook and corner.
Yeah.
And it brings the tumor completely intact, rules out a possibility of recurrence. And we have been following these patients for years and years. We have now more than 10 years follow-up,
Right.
doing well. And, with endoscopy only you can follow. In doubtful situations, intracranial invasions, and all that, you have to follow with the radiology. Otherwise, we don't even need radiology now. This is how
Exactly.
you follow. Now, look at this picture. This is T2 weighted, see
Mhm.
the amount of vessels inside the tumor. This is what kind of tumor is this?
Yeah.
Full of vessels. See, all these are flow wide. These are all big, big vessels into the tumor.
Yeah.
These are all ramifications of vessels, mostly arising from the internal maxillary.
Yeah.
In JNA, this is nothing but bunch of vessels with some, fibrous tissue. And these vessels classically do not have, muscular lining, so they don't contract. Now, once the vessel is damaged, it has a propensity to continuously bleed. It doesn't contract. That's how it gives hemorrhages. So, the goal in this surgery now, my principal tool, my man of the match is going to be, coagulator. As majority of the vascularity is towards the surface everywhere, and we'll use the coagulator in a sequential fashion. Everywhere the tumor is exposed, we'll use the coagulator.
Yeah.
That's how we'll minimize the bleeding. We will never advocate to enter inside the tumor unless you take the adequate vascular control. Never enter inside the tumor unless you expose from all around. I'll show you how to expose anteriorly, anterolaterally, posteriorly, medially, superiorly, everywhere, and then finally go on to the tumor. So this entire surgery, 90% of the time will be, spent or invested in exposure, vascular control, and then finally we'll get on to the tumor. This is the primary principle we are going to follow, and
So,
that's how
Satish,
we've been
before
able
I
to
leave
execute.
you for surgery, just one last question. Having watching you since years together, there is hardly any bleeding, but most of the people going for angiofibroma surgery, they always keep blood transfusion couple of units ready. So, what is your protocol on that?
The same
I
I
think
told you.
about this question.
Exposure, coagulation, exposure, preparation. Even this patient, I've been giving antibiotic and steroids for last 6 days now
Yeah.
to reduce the inflammation in the nose, because this tumor blocking all accesses to the sinuses, giving secondary infection, mucosal edema, vasodilation. You have to, prepare like sinus surgery by means
Right.
of giving antibiotics and steroids I've been giving to reduce the inflammation of the mucosa. Then more and more coagulation, taking the vascular control, not entering the tumor directly. All these and adequate exposure, adequate exposure is the key.
Yeah. So you don't need any blood to be kept ready for
Yeah,
that because you
we keep
okay.
standby, but
Mhm.
mostly we don't need too much of transfusion. Sometime 1 unit or so. Like this case also, we might be needing 1 unit because
Okay.
very vascular. We don't know how every tumor has a different structure. Some
Right.
tumor are more fibrous, some tumor are more vascular, and this
And,
tumor looks like more vascular. In
and
spite
one
of being
more thing,
17-year
Satish.
old, this is
Yeah.
too vascular looking like. Yes.
More thing, Satish. When you take out a bulk, this bulk contains a lot of blood, so you need some replacement. That's another logic about that.
Yeah. So this is all vessels only. This is all bunch of vessels only.
Right.
Secondly, with all these extensions frightening you, see, this is a huge infratemporal fossa extension. Believe me, it will come easy as like a baby.
Yeah.
No need to frighten. This infratemporal huge extension is going to come the most easier way, I will tell you.
Yeah.
Easiest. Anywhere it extends. If it is extending high up into the temporal lobe, it goes from the pterygoid roof into the temporal fossa. Similarly, it pushes the dura, you can bring it out easily. This cavernous component through the superior orbital fissure, you can bring out easily without any fear. So all these extensions need, after the dankers and medial part removal, all these extensions hold karna. Need just pulling out the tumor with adequate exposure. That's it. You don't need to frighten. And whatever, any given extension, you can remove endoscopically in a primary situation. Unless it is completely invading the carotid from all around. That's a contraindication, because you need a lot of control from the, carotid in case it lacerates. And when the tumor is 360-degree embedding the carotid artery, then you have to have, help from the endovascular team for the pre-op DSA, intra-op need of, coiling the vessel, pre-op coiling in case in a planned way, or, more neurosurgical help. So those are more complex situations, mostly revision, but by and large, in a primary situation, it is rarely needed. So
Okay,
we go
Satish sir.
Hello?
Satish sir, namaste. Good morning. Myself, Dr. Manoj from Varanasi.
Yes, sir.
Sir, what is your take for this pre-op embolization? We generally don't go for pre-op embolization.
Generally, we don't know. You're right. We sometimes get the embolization done. It depends upon the, feeders which are going to the tumor. Let me tell you, in this situation, say this. What you see from the angiogram, let me tell you, once you have asked the question in a proper way, how to look at the angiogram to find the need of, embolization. See this. I'm just showing you how to look at the angiogram. Can you see the common carotid artery on both sides?
Right, sir.
Now I'm going up. Can you see the common dividing?
Yes.
Yeah.
This is internal, this is external. What is this first branch of the external? Anybody here going here? This is superior thyroid. Anteriorly. Can you see anteromedially?
Yeah.
This is superior thyroid artery. Can you see?
Yes.
Now going further. See carefully. Two more branches. Can you see? This is your ascending pharyngeal. This one. Behind. Medially. And this is anteriorly. This is what? Facial artery. Can you see?
Yeah.
Right, sir.
You have to look at each and every vessel if any of them are supplying the tumor. See this? So this was ascending pharyngeal. You have to follow each and every. Now keep an eye on the ascending pharyngeal only. See, this is ascending pharyngeal. I forgot everything. This is ascending pharyngeal, and this is not going anywhere. Now, this is your facial artery. See this facial artery?
Yeah.
Now
Yes, sir.
following the facial artery. See that I'm following the facial artery going above the mandible. Now going further behind. See, it gives off. This is occipital artery behind. And here, this one is the lingual artery giving medially. That's the lingual, that's the occipital, and now the external carotid going behind the mandible and dividing into, this is internal maxillary and this is superficial temporal. You have to follow each and every vessel to know what all vessels are supplying to the tumor. If the tumor is supplied maximally by the internal maxillary, you can take control intraoperatively before entering into the tumor, because that is in front of the tumor and you can take endoscopic control. If some vessel is the principal one and supplying from behind, which you cannot access endoscopically without mobilizing the tumor, without going into the tumor, obviously you have to embolize, otherwise it will not allow you to work. So this angiogram will tell you what vessels are supplying, how they are entering into the tumor, and whether this needs embolization or not. Now see, in this particular case, this is internal maxillary. And here the internal maxillary is giving a branch from behind as well. This
Yes.
is a very, very superior part. This is probably middle meningeal artery giving from behind. But the rest of the internal maxillary This rest, the main internal maxillary is going into the tumor here and coming anteriorly. And that's why we'll take the control of this without needing embolization. Yes, if you take the help of aided embolization, you can embolize the middle meningeal to further reduce the vascularity. We are going to encounter some bleeding because of the, but we'll manage it with the other our tools, the Surgicel. We may have to use Surgiflow or something like that, but not the massive ramification is from the internal maxillary there. So once we take the maxillary in control, we'll be able to reduce the bleeding significantly coming to the tumor. This is how we work.
But sir, you are the God of ENT, and you have
Oh,
got
got it.
you have got hands of God. But it is not possible in every person who is operating this kind of angiofibroma. So any piece of advice for them, just like people like us, sir?
So
Sir,
get
आपकी मतलब every lecture and your every video is chapter of Gita. And even I have never met you personally, but I have learned so much from your videos, sir. I can't tell you. So people who have met you and who are in regular in touch with you, I don't know how much knowledge they are getting from you.
we are all learning from each other. Thank you very much, sir. The issue is what I am emphasizing, what I learned, and every day we are learning. And what I am emphasizing here is to focus on radiology to make your surgical life easier. All the difficulties you can encounter intraoperatively, you can presume on radiology and accordingly deal with that. Otherwise, you're going to get surprises intraoperatively, and you may have to cut a sorry figure sometimes to abandon the case, face more bleeding, complications. And according to the radiological imaging, you can warn your patient, you can counsel them that how it is going to behave, what we are going to do. So radiology is the key. Radiology is the science which is, developing much faster than the surgical science. It is technology. And it is time to take the advantage of technology as the patients are more demanding. Patients now expectations from the doctors are, obviously much more. And whatever we can fulfill, taking the advantage of radiology is something significantly leaves an impact. So this is what the information about this case so far what I have given is purely on the basis of radiology. I have not even opened the case.
Right,
So
sir.
let's see
Just
how it is
one
going.
question. Just
Yes,
one
sir.
question I received from somebody in my WhatsApp. They
Sir.
say if they have to order radiology, what one thing we should order for and what should be a complete requisition for the radiologist so that they don't miss out on anything.
See, it all depends upon the pathology you are looking at. Like in this case, clinically, you're suspecting a JNA. You have to order
Yes.
T1 weighted multiplanar imaging axial corner sagittal. Every imaging is shot separately in a MRI. Not like CT scan, you can reconstruct in any plane. T2 weighted in all
Right.
planes, T2 weighted fat suppressed in all plane. Angiogram, CT angiogram possible is much better than MR angiogram many a times. Then you need to have a contrast imaging. You need to have a diffusion imaging. Let me give you an advantage of diffusion here. See this. That's the contrast picture. Now I'm bringing the diffusion. Many times you have been referred patients in children having a mass lesion like this, assuming angiofibroma. Diffusion is a bioimaging. It will tell you what is the tissue content. it tells you the water content in the tissue. So malignant tumors have less and less water content, more and more nuclear cytoplasmic ratio. So they are not going to give too much of diffusion, because diffusion is what? This MRI is like a magnetic field. It creates a magnetic field, and diffusion weighted imaging measures the diffusion of water molecules in the magnetic field. So more water content, more diffusion. Less water content, diffusion restriction. So see this on diffusion. On this diffusion is a bright, full diffusion. This is the tumor with full diffusion. That means it has more and more water content. It is unlikely to be a malignant one.
Right.
Just a couple of days back, we have been referred a patient with the same nasal mass, child, for angiofibroma, got the MRI, showing huge diffusion restriction. We took a biopsy, turned out to be rhabdomyosarcoma. So, diffusion only can differentiate, and identify the malignancy to a more than 98% of the time. We can, on the basis of diffusion, we can preempt the diagnosis of malignancy. So, all sequences of MRI are very, very useful to reach to a correct diagnosis, to get some useful information from some or other point of view. So, every sequence is important. So, adequate radiology is the key. Without that, you cannot, reach to
Satish,
a.
the question was very specific. For angiofibroma, what radiology I should ask to my radiologist?
That's what I said, sir.
Yeah. So all this thing. Okay, I got it. So I think he got his answer. Thank you.
Yeah, the same one, what I said.
Yeah, true.
Satish, Dr. Murthy, Dr. PSN Murthy, one last question. If you don't have all these facilities,
Sir,
do you think a temporary clamping of the external carotid will do the job for a while?
not really, sir. I don't agree with this. The reason being, distal clamping is not going to help because this is not an end artery. Even if you clamp the external carotid, it is not going to affect the circulation there because it has.
It's a very proximal, highly proximal to clamping.
It
So,
has developed a lot of collaterals
the
and
external carotid is not going to help for that matter. It is not end artery. More and more distal clamping to close to the tumor site will help more and more.
Will
That's
have
why internal maxillary clamping helps more. More than that, if you do a microvasculature embolization right to the, microvasculature of branches of internal maxillary, it will help more. So, it all depends upon, kind of embolization is done. The, efficacy of embolization all depends upon the competence of the intervention radiologist, because otherwise it is sometimes risky as well. If your material happens to go into the internal carotid, circulation can give hazardous effects. That's been reported. So,
highly selective embolization is the key.
yeah, yes. Nowadays, liquid embolization, highly selective embolization, yes, definitely useful. I don't deny that. It calls for a very, very competent work from the intervention radiologist. It costs like anything, which is again, sometime or most of the time, the cost is more than the cost of the surgery itself.
Surgery itself, yeah.
Yeah. And if you follow a particular surgical protocol, that's what I'm going to share with you. Most of the time, you get away without embolization, without transfusion. So it's all depends upon planning.
I think most of what I have watched you hardly have gone for embolization. I just remember one or two cases where you
less than 5%
was from behind.
Less than 5% situation.
Yeah. Less than 5% was from behind.
Satish bhai,
Less than 5%.
Yes, sir.
We can.
Yes,
Satish
sir.
bhai,
Yes.
Satish,
Yes, sir.
Satish bhai,
Yes, sir.
we can have rest of the discussion while operating.
Yes, yes. We can continue with the surgery.
Yes, sir. We can have rest of the discussion while operating. Please continue.
So we can start our surgical parts and we can continue the discussion later during surgery. Feel free to interrupt me any point of time. In a couple of minutes, we'll be back with the endoscopic picture. Hello. कर दिया करो. Hello.
Yes, sir.
One of the strategies our anesthesiologists adopt in these cases is to load with the fluid before surgery. Like this patient is loaded with more than a liter of fluid so that whatever blood loss happens is a diluted one.
Right, sir.
So the need of the transfusion is further reduced. Then this surgery is done under hypotensive anesthesia as well. Here
How
the
much-
vessels are pure arterial ones.
How much fluid you give, sir, generally?
More than a liter, sir.
Okay.
उसलिए क्या कह रहा हूं? More than a liter of fluid. And secondly, hypotensive anesthesia. Unlike sinus surgery, where the bleeding is mostly from the capillaries, here the bleeding is mostly from the larger vessels, arteries. So hypotensive anesthesia is the key in these situations. This is the primary picture. Are you getting the endoscopic picture
Right.
now?
Yes, sir. Very clearly.
That's the tumor. That's the tumor going in the posterior part of the nasal cavity and nasopharynx. And see the intense red, angry kind of a tumor. So I'm just applying adrenaline on the surface. See, the moment you touch it, it starts bleeding. Even the slightest of the contact you're on the surface gives bleeding. Can you see?
Right, sir. But till now, tumor is not knowing who is going to operate him, sir.
Huh?
ट्यूमर को अभी पता नहीं है कि कौन उसको ऑपरेट कर रहा है. After that, it will stop pushing, sir.
You have to take the measures accordingly. Or they. So here, couple of minutes will decongest the surface. This tumor looks very vascular. I could see the arterial ramifications within the tumor, extensive ramifications. Looks very, very vascular. Let's see.
You are putting this adrenaline with Merosil.
Yes. Initial surface decongestions on the nasal cavity. See this to open up the nasal space. Much better.
Right.
Tumor I have initially covered with the marrow cell so we don't come onto the surface with our instrument to damage it. Our goal is to give a modified Denkers first, so that we can, as I showed you on MRI, the kind of exposure we need. We need to remove this entire medial wall.
Mm-hmm.
That includes the lateral wall of the medial wall of the maxilla and the inferior turbinate as a separate bone. This is pyriform aperture.
Right, sir.
So, and our upper limit is going to be the roof of maxilla, that is the floor of orbit.
Yes.
So here, वो दे दूसरा वाला देख. So first I'm using this coagulator wand on the coagulation mode.
EVAC 70.
This is not EVAC 70. We use from ArthroCare Precise Max, and this is the different vein I've been trying from bones. Yeah, that's a different make bones. In between, just for the trial I've been using. See what I am doing is surface coagulation.
Right, sir.
See this periosteum, which is richly vascularized otherwise.
Mm-hmm.
We have to keep all the time the fluid, this field better and better. See, this is my anterior limit. Now see for the audience, what is this here? Anteriorly, if you come to anteriorly here, this is your lower alar cartilage.
Yes.
So never come too anterior cartilage to give a deformity. See, I am right. Aperture. If you come a centimeter anterior, you are going to damage the ulnar cartilage, and that's a disaster. Then you have to need to reinforce with the cartilage. Now, I'm using the cutting one.
Mhm.
See, removing this mucoperiosteum.
Yes.
This cobbleter doesn't work on the bone. Never try to use on the bone, otherwise that will ruin the wound.
Okay.
This is my anterior limit. See the piriform aperture?
Mm-hmm.
This is the bone of the piriform aperture. Inferiorly, this limit is the floor of the nasal cavity. See this floor?
Right, sir.
Then this is the inferior turbinate, which has to go accordingly. If the bleeding comes on the bone, see this? Bone
Mm-hmm.
coming from the bone, never try to use the cobbleters.
Okay.
This is the inferior turbinate, which is a separate bone which I am taking off. This is the bone of the inferior turbinate. See this? Bone of the inferior turbinate.
Yes. Yes.
And this is where the inferior meatus is. See this inferior meatus?
Yeah. Very clearly, sir.
Yeah. So now I can take all this inferior meatus, mucoperiosteum as well. You have to remove everything under vision.
For this bony part, you don't use debrider and other thing. No, only this cobbleter.
Part, yes, the bony bleeding is never going to be come under control within Kala. Band. Fast. The bony bleeding, let me tell you what can be done to the bony bleeding. See, like this bleeding coming from the bone?
Yes.
I'm
Yes.
using my suction
Great.
cautery, insulated suction cautery. See this?
Yeah. Yeah.
On bone, never apply your cobbleter. Here again on the bone. See this? So any bleeder coming from within the bone, see this?
Yes. Yes.
You can apply your suction cautery rather than using the cobbleter. Wherever the bleeding coming from the bone, you have to be careful not to use your cobbleter. Bas. See, now the field is good. Give rider. This part of the turbinate, see this? I can take away with the micro debrider. Band. You have to remove this inferior turbinate till the posterior wall of the maxilla.
Okay.
All this medial wall will go till the posterior wall of the maxilla. See the soft tissue you can debride. Bony part you cannot simply. This is the inferior turbinate bone. Irrigation all the way continues. This is what my assistant has been doing, irrigation, irrigation, irrigation. That's the inferior turbinate bone. See this?
Yes. Completely out.
As you go behind, more and more bone has to go. Cobbleter. Section. Like this. Small pack. So now This part I can leave here for a while. See this? My medial wall exposure is good now.
Yeah,
We'll
almost
go
complete.
further behind as we remove till here. Now we go to the anterolateral wall. And since the tumor is going far lateral, we need adequate anterolateral exposure. See, this is piriform aperture. This is my subperiosteal plane. Maintain this subperiosteal plane as you go laterally. There you divide the anterosuperior alveolar neurovascular bundle. By and large, your lateral limit is till the infraorbital canal. But nowadays, what technique Professor Paul Casanova introduced, we can even go beyond. Couple of times we do the transposition of the infraorbital neurovascular bundle to go even beyond. So now it is limitless. With the advancement in the technology, advancement in understanding the vascularity, equipments, surgical experience, this technique is becoming, the limit is becoming unlimited, sort of a thing. See, this is the periosteum which I am coagulating.
ENT surgery has become a game of power instrumentation.
Yeah, instrumentation has a big role.
Yes, sir.
See, now this part of the bone I have exposed has to go. And this way we will reach head on into the maxillary sinus. So this thin bone anteriorly I can punch out. Rest I have to drill, or you can use a chisel hammer. So if I drill here, I will be right into the maxillary sinus head on. See this. I'll be right into the maxillary sinus head on. And then I will show you how much the bone to be removed superiorly, laterally, everywhere under vision. The most important structure coming in the lateral wall is the nasolacrimal system, which we have to deal with to prevent future epiphora. See, that's the entry into the maxillary sinus.
Right, sir.
Section. That's the interior of the maxillary sinus, you can see.
Mm-hmm.
A tumor bulge behind in the posterior wall. You can see that.
Yes.
So now you have to widen this more and more. This is my classical stylus from the Medtronic. This is coarse diamond, 4.5 millimeter, using 75,000 RPM with irrigation, under vision, 15-degree shaft, shaft not coming in the way. And you know, it makes your life so easier. क्यों इरिटेट कर रहे हो? उठा लो ना, पकड़ लेना हाथ में. उठा. 1 घंटे में जाना चाहिए. See, my superior limit is going to be the floor of the orbit. We don't want unnecessarily accidental entry into the orbit at this place. I will further widen it more and more all around. This is our principal exposure, paramedian exposure to reach to the paramedian skull base. This you can do fast with the chisel and hammer as well, but that cannot be so precise. See the opening?
Yes, sir.
See the level of the roof of the orbit behind? See the level of the floor of the orbit. Now, since I have thinned this bone, I can remove it, punch out. See this?
Yeah.
Just behind is going to be the nasolacrimal duct. Behind and up is the nasolacrimal duct. This is your nasolacrimal duct there.
Mm-hmm.
Lower part I can remove. Duct is above. Wash. Yes. Now give me the drill further. See, I can go on, keep removing laterally till wherever we want for the adequate exposure. See that? Cobbleter. Cobbleter. See, whatever lateral exposure you want, you can take at this moment. See what I'm doing? I'm cobbleting this periosteum to stiffen, so it doesn't prolapse with the section inside. That's a very important point. Otherwise, it falls in with the section and makes your life difficult. See this? Give me the drill. See now?
Yeah,
More bone we can remove now
yes. The cobbleter is the man of the match.
throughout the surgery.
Yeah.
See, now more bone exposed, more bone you can remove. See?
Yeah.
Move complete, even if you want to complete anterolateral wall.
Yeah.
This is my left infraorbital now. See there.
Yeah.
That's the canal laterally.
Yes.
Here I am not going lateral to it. That will be adequate for me, as I am not going to, don't want to go lateral, as I will pull the tumor, whatever going laterally, under vision. See the exposure toward the floor. This now toward the roof.
Yeah.
थोड़ा पीछे करना सच. See, I am flushing with the floor. So I cut my nasolacrimal duct sharp close to the floor. If I
Yes.
leave it hanging, it can get fibros. So I don't want to leave it overhanging. You have to flush right to the floor.
Floor.
That is the key to prevent epiphora. See how superiorly we need to go. This is all bone over the nasolacrimal duct. Can you see?
You are making the nasolacrimal duct bare of the bone, and then you make a sharp cut.
Yes. Can you see the duct inside?
Yes, sir.
Yeah. Yes.
See the duct inside. See the duct inside.
Yes.
Drill. See how superiorly you are supposed to go. There's a very important catch point. And this drilling is so precise. It really, this cannot be done without such a drill. So precise. Okay. See the duct within the canal?
Yes.
Yeah.
So you have to remove the bone all around. बता दे। Debrider. See now, I'm just flushing it from all around. खींचो मत। See the bone all around, the duct being completely skeletonized. Drill. तो खींचो मत, खींचो मत। Scissors. See skeletonization. See now, being cut sharp. Hello,
Yes, sir.
Yeah, you can see that.
that is what we want. एक बार में नहीं उठा. That was the uncinate process I removed. Could you see?
Yes.
Behind the nasolacrimal is the uncinate process. See this?
Yes.
Mhm.
Now, debrider. See what we are getting is this exposure, head-on exposure to the posterior wall of the maxilla. Could you see very clear or not?
Yes, very clearly. Very clear.
Above is your nasolacrimal system. See this?
Yeah. We could have, yeah, we could see the,
This is not going to come in our way now. Now, छोटे-छोटे दो piece दे दो. See our tumor behind. This is the posterior wall of the maxilla behind. I hope the picture is good there.
yeah, very good.
Yeah, very clear.
Now I will do some more work on the medial wall. This part I am covering the tumor. Yeah, one more. I am covering the posterior wall. Now this is the posterior wall, and I have to flush this medial wall all the way from floor to the orbital floor, flushing the entire medial wall completely. This tumor has a propensity to invade the inferior turbinate, propensity to invade the septum, but it never invades the sinus mucosa. It never invades the nasal floor. So accordingly, you have to take a call. See, you can keep optimizing your field by means of coagulating the mucosal surfaces. Bony surfaces you can remove. The all bones you have to remove. See this? Keep removing the bone. Now we will flush this with the floor. See this with the nasal floor. If you don't flush it, this will, hamper your instrumentation in the depth. So everything is being done for exposure. Now we have a good anterior exposure and anterolateral exposure as well. See, our instrument should go inside uninterrupted. This is how the space being created for that. See this medial wall being flushed with the floor. You can see with the floor here.
Yes,
Yeah.
yes, Dr. Satish.
At the same time being flushed with the posterior wall behind. See the posterior wall coming in pictures.
Yes.
Yeah, we can see that. Is the posterior wall thin?
Yeah. This is posterior wall. Divider. See, that's the posterior wall of the maxilla here. Where you see the tumor bulge.
Yeah, is it very thin? Yeah, is it very thin?
Is what?
Is it very thin?
Yeah. Because of the tumor bulge, the wall become more and more thin with more and more bulge. See the remnant of the posterior inferior turbinate. See this?
Yes.
Now see more and more tumor surface is getting exposed, and this
Yeah.
tumor is involving the middle turbinate. See this involving the middle turbinate?
Yeah.
Yes.
Yes.
More tumor surface is exposed, require more surface coagulation. This serves two purposes, not only to devascularize the surface and reduce the bleeding, at the same time allow the tumor to shrink.
So far, we have seen hardly any bleeding.
Yeah, just this is my more and more irrigation, which even
Right.
gives you,
A much clearer field.
Irrigation is with normal saline or warm saline?
ringer or saline. See this tumor surface?
Yeah.
वही है. See the tumor surface, I am coagulating.
Yeah.
That's a part of the inferior turbinate. See, it has shrunken the tumor as well, along with devascularization on the surface.
Yeah.
This bone is the perpendicular plate of the palatine bone.
Yes.
This bone.
Yeah.
Yeah.
This has this anterior orbital third process and posterior sphenoid process, and in between them is the sphenopalatine foramen.
Yeah.
See this bone thoroughly.
Yeah.
So now, again, continuing the same thing. See this flushing with the posterior wall. See the posterior wall now.
Yeah.
See the picture, posterior wall completely flush with the medial wall.
Yeah.
No intervening bone is left. See this?
Yeah.
Yeah.
This is the kind of exposure which completes this modified Dankers. This is all posterior wall of the maxilla. Now what I am doing, removing this mucosa. Wash. Removing this mucosa from the posterior wall. See this very clear?
Yeah.
Exposing the posterior wall of the maxilla thoroughly. See, bone is dehiscent at places.
Yeah.
As the tumor is bulging from behind, making this wall more and more prominent and distant.
Yes.
Now we have to remove this. See this thin bone, you can fleck off.
Yeah.
If not thin, you have to drill off or you can punch out, whatever. What I'm exposing is the pterygopalatine mucoperiosteum. Later. See the periosteum there behind?
Yes.
I can coagulate.
Yeah.
See this to make my life better.
Yeah.
That's the beauty of coagulator. Very good. Now I can take the help of bone punch, this Carrison punch.
Yeah.
You can use drill, punches, whatever, to remove this bone adequately. Nothing is hard and fast the way you are used to. You can do that. I been widening little more extensively because we have a huge lateral component.
Yeah.
I need to create adequate space to bring it inside. अब later हटा हटा ये हटा तुरंत हटा दिया. See more and more periosteum in exposure.
Yeah. Yeah.
अब later. Just a minute.
Satish, so there are a couple of questions from the audience. Can we
Yes,
take it?
please, please.
Yes, sir. So there's a question from Dr. Venkatasuriya Madhuri Devi from Visakhapatnam, Andhra Pradesh. So please comment on the role of dynamic MRI in assessing JNA vascularity.
Roll off.
Role of dynamic MRI in assessing JNA vascularity.
Which MRI?
Dynamic MRI, sir. Role of basically MRI.
I just your voice is breaking. Which MRI, boss?
Imaging.
Just one minute.
They have written dynamic MRI.
Dynamic MRI. Dynamic MRI.
Yeah, he is asking about dynamic MRI.
See, dynamic MRI is useful to assess the circulation. It aids in differential diagnosis sometime to differentiate the tumors like schwannomas from JNA, which have a contrast enhancement at certain part of the cycle after the contrast injection. Here, it is not so useful as far as the diagnosis is concerned, because here angiography is adequate to give you, information about the feeders. Diagnosis is based on the extensions. So dynamic MRI is particularly, I would say, not so essentially useful. That is more useful in the lesions of the parapharyngeal space, where you have a doubt whether it is a schwannoma, whether it is a paraganglioma, whether it is something else. So dynamic MRI is useful in places, but not very informative in cases of JNA, because that information we already have.
Yeah.
See more and more exposure.
Yes.
Any other questions, please?
No, sir. As the questions come in, I'll let you know, sir. Right now, that was the only question.
Yes, please. Feel free.
Sure, sir. Thank you, sir.
Debrider. See, the focus is more and more on exposure.
Satish, how far laterally you'll go?
Laterally depends. See, this wall I have given anterolateral exposure.
Yeah,
This wall I have given posterolateral exposure. Only this bone is left.
yeah,
There's a centimeter bone is left in between. See this?
yeah.
This is not an invasive tumor. This is just a pushing front curved section. I don't really need to remove this bone. There is not malignancy.
Yeah.
So I can pull out. I have adequate exposure to see from this anterolateral window and adequate exposure to pull the tumor from this posterolateral window. I don't need to remove this medial part of the bone unnecessarily.
I think once we have studied the scans and then we know where the extension is, it is the tumor which decides up to what extent we have to go. Will you
Yes.
agree with me, Satish?
Yes. How's the picture, sir?
Excellent.
Give the call later. Cloud forces. Yes. Come later.
Dr. Satish, there is a question from Dr. Balakrishnan from Manipal.
Yes, please.
Please show foramen rotundum and Vidian canal. I don't think it is very significant here.
Yeah, I will show later.
Yeah,
I will
that's
show.
why.
I will show.
Yeah.
I will show later. Those are in close vicinity of the tumor involvement, but since they have asked, I will show.
Yeah.
Vidian must have been ruined by the tumor, but I will show you the location.
Yeah.
See the bone removal.
Yes.
See the adequate bone removal everywhere. Okay?
Yeah.
Come later. This is the periosteum. Now I will incise the periosteum. See what I have done? I have incised the periosteum.
Yeah. And separated.
To enter into the pterygopalatine fossa. That is the fossa per se. Come later. Now we are on the tumor surface.
Yes. Which part of angiofibroma is most vascular? Again, probably it depends on the feeding vessels, no?
Yes. So by and large, peripheral part everywhere is vascular.
Right.
As it grows more and more, the central part becomes more and more necrotic.
Right.
See my vessel coming here.
Yeah.
Yeah. Yes.
Can you hold this? See, this looks like one of the vessels.
Yes.
What I will do,
Goblet it.
yes. Can you see the main vessel behind?
Yeah.
That looks like the main IMA.
Yes.
See, I told you I'm looking superiorly because
Mhm.
my angiogram told me it is quite high up. See this?
Yes.
See the
Yeah.
level of the floor. I am seeing so high up.
Yeah.
If you had seen the day before demonstration, it was showing 1.5 centimeters. So I went inferiorly and I found the vessel there.
Yeah.
With such a massive tumor, identification of the vessel is always a challenge.
Yeah. You need a great exposure for that. And
I will show you exactly. Just I am exploring this region closely. Just a minute, just a minute. Just a minute. See the infratemporal fossa fat. Infratemporal fossa fat in picture. Hello.
yeah, please go ahead. Satish, there is a question when to clip and when to coagulate. I think
Clipping
people want,
is a more certain method,
yeah,
more secure method. Coagulation of such a large vessel may not be so effective.
right.
And this vessel, particularly when supply JNA becomes, enlarged.
मत दो.
Yeah, that looks like our main vessel. I'm coming to in a minute's time. That's the main vessel.
Yeah.
I am working more and more laterally and up
Yeah.
because the tumor mass displaces. इसको pull कर, इसको pull कर. Just pull this a little bit. Pull this, yes. This is the vessel. Here, this is.
On the upper lateral part.
That's the main vessel. Can you see the vessel?
Yes, sir.
नहीं जाएगा वहाँ. Later. It is so embedded within the tumor.
Yeah.
That's the important part of this surgery. Just keep opening up the space because I'm far laterally to take the trunk of the vessel.
Yes. We have to make a space to put a clip or anything in that.
Yeah. Let's define first.
Yes.
Use tumor mass, use bulk.
Yeah.
That is the surface of the tumor.
Okay.
When you look for it, widen more and more surface.
Mm-hmm.
When you widen more and more surface, you get more space. Yeah. See one of the branch.
Yeah.
This is one of the branch. ये पता. Really, this is the vessel.
Yeah.
There are n number of branches. Bigger the tumor size, more are the branches.
Yeah.
Every branch looks like internal maxillary itself
Yeah.
because it is enlarged.
Yeah.
So just have patience. Yes. Flip. Coagulate. I will coagulate this.
Yeah.
Every such bleeder
Mm-hmm.
can take you to the main vessel.
Yes.
Yeah, this is the vessel, one of the vessels.
Yeah.
Take it off. See this, I am cutting it off
Yeah.
to go on the tumor surface. That is all tumor surface. One of the branch I have cut.
Yeah.
A lot of vessels in the convolutions of the tumor. See the area. We are right in the infratemporal fossa
Yeah.
with this kind of exposure. No. Okay. Yes. Yes. See, I am right in the infratemporal fossa.
Yeah.
See?
Can we get little more lateral exposure by cutting the bone?
Yes. Wait.
Yeah.
See?
Yes.
Little more lateral.
Yeah. Can we get little more lateral extension by cutting little more bone, drilling it?
No, not really needed. We have ample of, space.
Mm-hmm.
This window, and we can see the tumor surface everywhere.
Yeah. And a gentle pulling will not tear it off.
Yeah. So one or two branches we have already coagulated,
Coagulated, yeah.
cut. All this is all tumor surface,
Yeah.
very nicely accessible.
Mm-hmm.
Give me a gauge piece. See, to orient you with the infratemporal fossa.
Yeah.
बात करो. Hello?
Yeah, please go.
हाँ.
जी सतीश भाई, डॉक्टर दुबे हियर, भोपाल. हेलो.
Hello?
सतीश भाई.
Yes, sir. I was on some phone call. Sorry.
अच्छा.
Sorry, please.
Nice to see you.
Arre, sir. Pleasure to have you always. So this is the exposure of the tumor, infratemporal fossa. You can
Yes.
see the entire surface of the tumor and see some of the
Fat.
Intratemporal fat is coming in the view.
Yes, sir.
See, more and more infratemporal fossa fat you remove, you have more on the bigger part of the tumor surface.
Yes.
See, such a nice window you have.
Yes.
later. We have more than adequate exposure for just coagulating the surface. Many of the branches, tumor branches. See, one more I am coagulating here and cutting at the same time. You cut, more you release the exposure. Can you see?
Yes, yes. Most of the part is out.
I mean exposed.
Yes, exposed. And you always say
And
exposure is
cutting.
the key.
See? Coagulate the vessel. See this?
And cut.
Cut. So this is way more and more tumor getting exposed this way. I'm looking for if some more, major tumor vessel, if I come across, divider. See the exposure of the infratemporal fossa.
Yes.
Later. Improve this fat, remove this fat and some soft tissues coming in the way to improve your further exposure. This could be one of the vessels as well. Tumor surface.
Good morning. Good morning, Dr. Satish sir.
Yes,
Dr.
sir.
Tushar Kanti Ghosh here from Kolkata.
Yes, boss.
Beautifully exposed basically. Now you
My
target to clip
infratemporal fossa
intermaxillary. Yes.
is exposed. Entire infratemporal fossa is exposed, and all the possible feeders on the surface I have
Yes.
coagulated here. Give me a gauge piece. Just for the timing, we'll leave a gauge piece over here with this exposure. Yes, boss. Anything to comment at this stage?
Just target to clip the intermaxillary artery,
Yeah. So we found some of the branches
Yes.
supplying, coming on the surface, With so many lobulation
Yes,
of the
yes, yes, yes,
tumor,
yes. So now no bleeding basically.
the area looks good. That is the
Ah,
infraorbital nerve above. You can see.
yes, yes, beautifully.
Can you see the infraorbital nerve? See the exposure of the infraorbital nerve above.
Yes, yes.
This is the complete exposure here. I'll leave it here for a while. And then we have this anterior exposure, we have anterolateral exposure. You can see. Now we'll improve our exposure
Superior.
superior to it, behind and medial to it. The brighter. Give me the scissors. See, the middle turbinate is involved here with the tumor. You can see
Yes.
very clear.
Yeah, so cut it, your target.
Below it is involved with the tumor here. So I cut over here. Just above that. Like this. The brighter. And then we'll go in the ethmoids and the sphenoids from above. Quickly. This is ethmoidal dissection. This one. Your lateral limit is the lamina papyracea. Quick. This you can finish off quickly. There is no. Just once define the lamina and then go along. Yes. See the tumor going up? Hello?
Yes, yes.
See the tumor there?
Yes.
This is the tumor there. And that is the sphenoid sinus behind. Pass the close. See this. See this? The tumor from superiorly. Please see this. This is the superior surface of the tumor you can see.
Yes.
Yes.
Very clear?
Very clear.
So more and more surface coming into picture, more and more surface coagulation is required. See, more and more surface coagulation. I hope you are oriented.
Yes, sir.
Yes.
See the interior of the sphenoid sinus below.
Very
Yes,
good.
yes, yes. Likely optical optic nerve bulge.
That's the interior of the
Sphenoid.
sphenoid sinus.
Yes.
And this is the superior surface of the tumor. See the complete superior surface of the tumor. Complete superior surface of the tumor. See the medial and lateral tumor in continuity here. Hello.
Yes, sir.
Yes, yes.
So your target now posterior septectomy?
Yeah. So not now, but now this support the tumor is exposed. I will coagulate it first. Remove all intervening bone everywhere. See, now I will coagulate this entire surface. See the entire superior surface very distinctly. Is that clear?
Yes.
Your coagulator is the key. See this. See the superior surface of the tumor?
Yes, yes. Very clearly.
So this is all now medially. See this? This is the attachment to the septum.
Yeah.
Wherever it takes attachment, it acquires additional blood supply. Periosteal blood vessel. So here I have separated from the septum. See, very clear. See, completely separated of septum.
Yes.
Yes.
So quickly we have achieved the superior exposure. This is anterior exposure. This is anterolateral exposure. Tumor surface being coagulated all the time. And this is your superior exposure. Clear?
Yeah.
Right.
Leaving some right. Now we improve my medial exposure and exposure from behind.
I think Satish bhai, except from sphenoid sinus, it will take blood supply from everywhere it is attached.
Yes. Blood supply wherever it takes attachment to.
Okay.
Give me a pack, small pack. See the tumor exposed from so many sides.
Yes.
Now I will go medial to it. We need to have a full exposure all around when we pull it.
Right.
See this?
Yes.
Now medial exposure. Yes. नीचे करो.
Sometimes nasopharyngeal attachment bleeds very curious.
Yes, yes. So what you need to do that? See now I am going medial to it.
Yes.
I am removing this posterior most part of the septum to go medial to and behind this tumor. This septal mucoperiosteum I am removing. This till the posterior edge, you can see.
Yes.
See this. This will give me opportunity to control the tumor from medial side, from behind, everywhere. See, you can go to the opposite side. So that's a very important part of the tumor control as well as tumor delivery. Can you see I am in the nasopharynx?
Yes.
These medial attachments invites the blood supply from the opposite side very often. See this? Pharynx very clear. Later, yeah. So now I will cut off my blood supply coming from the opposite side completely. See this? This mucosal coagulation, some mucosal coagulation completely lie in a linear fashion will rule out any blood supply coming from the opposite side. This has no attachment on the adenoid surface, never. Only this nasopharyngeal roof periosteum is the source. See the exposure from the medial side and behind? I hope you are oriented.
Yes, yes.
Tumor has been lifted. बता दे उसको. Yes. See posteriorly everywhere. What I have ensured, the nasopharyngeal roof periosteum. See this? This is the key which invites the blood supply from the opposite side, which I have completely, see this? Coagulated. Ensure there is no source of bleeding from the opposite side. Okay? See this tumor, which is the medial surface coming in exposure, being coagulated now.
Yes.
We have gone far medial and behind the tumor, the entire surface is coagulated. See this? There. See the entire tumor surface being coagulated wherever it is getting exposed. Look at the tumor, look now. It was having such an angry look earlier when we started. You remember?
Yes, beautifully.
We have exposed from all around. Now is a very crucial point to divide it in the midline, at the lateral nasal wall, to remove the medial component. Let me show you. See my basic exposure?
Yes.
That is the point at the junction of medial and lateral component. This is medial, this is lateral. Section. Can you see the distinction very clear? Clear or not?
Yeah, clear, sir. Looks like polyp only now, bloodless field.
No, it has blood bipolar. Now what I'll do before dividing with the coagulator, I'll take additional help from the bipolar here. See this bipolar?
Yes.
At this bottleneck. I'm using the bipolar at this bottleneck. Now I will use the calculator and divide this medial lateral junction. In a minute's time, this is planned division, so that we can mobilize the entire lateral component. Okay. Since it has a major lateral extension, so we had to resort to this planned division. Connected? Any bottle? Okay, Viru. Where's the coagulator? खत्म हो जाएगा. Okay. Hello, पकड़ इसको middle.
Hello.
Hello, everybody.
Yes, Dr. Satish.
Yes. Now
You are separating with coblation, lateral to medial.
Accepting little bit of the bleeding which will tackle, I am doing this planned division.
Yes, yes.
At the edge of this, see the bone there inferiorly, bone. See the bone?
Yes, yes.
This is a proper planned division. Full. See, with full irrigation. See the posterior wall? Expecting little bit of the oozing. See, I am just bang on the bone. See, this entire component has been pushed down. Can you see the nasopharynx?
Yes, yes, yes. You will now remove the medial part from the oral cavity.
Yes. See this bang on the bone, subperiosteal. See this mucosa, periosteum.
Yeah.
It's tenting. See this periosteal attachment?
Yes, 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 yes. An assistant role is very important. He pushes the tumor, so plane will be
See this, it
clearly
is
seen.
free.
Yes, sir.
I can remove even through the oral cavity, nasal cavity also, not very big one. Give me the forceps. आता इसको clean section. Yes, pull this. See this? This is the medial component. Could you see this? Am I connected?
Yes, yes.
So medial component I have pulled. Section. See the nasopharynx very clear?
Yeah.
Some of the vessels here at the pterygoid zone you can see. This pterygoid bleeding is one thing you must understand, that this, see the bleeding coming from the pterygoid bone. This is difficult to control like this because it is mostly venous, and we'll remove this pterygoid process later. We have achieved, we have removed the medial part
Yes.
and everything is under control. See this? Medial part has been removed and we are ready to take on the lateral part now. See this?
Hmm.
This section color. This pterygoid bleeding, the bony bleeding,
Sometimes drilling required.
yeah, it is always difficult to control, in the sense frustrating because it is venous bleeding. See this bone. So what I am trying to do here, I am using my section cautery over the bone for the time being. See this? Bleeding coming from the bone. Cobbler. Now from this soft tissue can be controlled. See this? Much better now? Okay. Yeah. Color. See, whatever bleeder coming from the bone, see this? Never use the cobbler over it. Yes. See, the field is good now?
Yeah.
So there are many ways to control the same bleeding. Now give me a piece of Surgicel. See, this tumor which we have cut here is obviously going to bleed a little bit.
Yeah.
See this? This one. Now this surface I will press for a while. Under the using the Surgicel in front will control for a while. See this?
Yes, yes.
There are ways to control the bleeding differently at different places. See the field now?
Yeah.
So we have divided the tumor with little bit of the bleeding which was acceptable. See this? Not the main part, we have huge lobulated tumor laterally which we have to bring out.
Yeah.
Watch please. These Surgicel is so good. Vagisil is what an excellent tool on the soft tissue surfaces. Just pack with the Cervicel and pack press on with the gauge piece. See, everything, no bleeding.
Yeah.
Now, coming to the lateral part. We took the advantage of this exposure and felt the various parts of the tumor in front of us. See this? I told you this removal of the lateral part now with this exposure is much, much easier. Much easier than removal of the medial part.
Yeah.
Yes, yes,
You
yes.
have to hold it, advance your hold, keep bringing this tumor out and keep using your coblet on the interface. See one of the big vessels. Huh?
Yeah.
See now? I'll separate this vessel from the surface. Yeah. So anyway, see now the most important part. See this tumor being held. Section. One more process. Can you see?
Yeah,
Yes.
Yeah,
just
very
beautifully.
clearly. Very clearly.
The tumor. So one by one, we are advancing our instruments to pull it. See this tumor which is being pulled.
Yeah.
Now see that such a big tumor being pulled.
Yeah.
See this surface. This is all, oh, what a massive one.
Yeah. And the surface don't have any adhesions. When we pull it out,
What?
there is
This
no
is
any
this
bleeding.
is pushed.
Yeah. So
I have removed my gauge piece.
yeah.
आगे से पकड़, वहां से पकड़. Hold. See, that's the tumor lobulation. And this is
Yeah.
what I'm separating is the surface structure. See this? This section with the cobbleter only.
Yeah.
Advance more and more. Pull it. Okay. Pull it more and more.
And with coblation, surface bleeding will stop.
Cleaning the surface. See that? There are
Yeah.
surface vessels. Surface vessels. We are cleaning the surface.
Yeah.
The rider. Everywhere. Just clean the surface of anything else than tumor. See this?
Yeah.
Tumor has been pulled and held medially.
Yeah.
See how the adhesion being taken.
Yeah.
Just beautiful.
Cobbleter, wait. See all the surface adhesions. Going into the tumor. You mobilize the adhesion, move the tumor is coming inside. See now the last bit of the tumor.
Yeah. So nicely come out.
Yes, yes. Small vessels we tackle with coblation.
Yeah. All.
If interested, you may get back, no?
More these adhesions, I will not know the tumor will be released.
Yeah.
Basically, it is coagulation and irrigation that is going to help you. You don't have to put a pack and wait for it to come out.
No, it has to be done under vision. See now,
Yeah.
adhesions released and tumor is pushed.
Delivered.
Under vision, you have to see slowly after releasing adhesion, the tumor is
Yes.
got into the nasal cavity. Can you see?
Yeah.
The entire tumor is now in the nasal cavity.
Yeah.
What irrigation? Remove this.
Normal saline. Normal saline.
Yeah. Wait. Tumor is pushed in the nasopharynx.
Yeah.
See this? That looks like the vessel behind. Can you see that?
Yes.
Yeah.
What I will do, just give me a clip. See this vessel?
Yes.
Most of the branches we coagulated.
Yeah.
And I'll put a clip here. Give me the coagulator. And cut this.
Yeah.
Now my tumor is placed. Give me a pack for a while, just to see the structures better. I'll show you. Things are under control. A tumor I have pushed in the nasopharynx. I will show you. See now. Metal part where we remove the tumor is being packed. Okay?
Yeah.
See this part. I will remove the pack and show you later on.
Yeah.
Where the tumor? Tumor is here.
Yeah.
What's this about? I'll take section in other end. Yes. Now see where the tumor has come. Some more parts are there. I will show you.
Yeah.
See, tumor is here in the nasopharynx. See the huge tumor.
Nasopharynx. Yeah.
Entire lateral component has been pushed in the
Nasopharynx.
See this? This one
Yeah.
may be too big to be removed from anteriorly. Lux. See this?
Yeah.
Oh my God.
Yeah.
Beautifully.
Big one.
Yeah.
Big lateral component.
Yeah.
Dumbbell set.
Still we have some of the tumor remaining in the pterygoid
Yeah.
and in the orbital fissure.
Yes.
See now the nasal cavity is opened up again.
Yeah.
Remove this lateral peg. Give me a wash. Give me a section. Come out the bleeder, the lateral part. See now with this section, you can control any bleeder.
Yeah.
Later. That is the remaining tumor above.
Yes.
Little bit.
See the infratemporal fossa surface. This is
நல்லா
good.
இருக்குமா நல்லா
This
இருக்குமா
is a little bit of the pterygoid.
ஃபோன் பண்ணியாப்பா
Little bit of the pterygoid venous oozing. That's it. Nothing much.
வந்துருவாங்க ஹஸ்பண்ட் நாளைக்கு வராரா ரைட் 9 o'clock புக் பண்ணிட்டேன் ஒன்று சொன்னேன் வெப்பன் இருக்கேன் ரைட் வந்துருவாங்க
Dr. Guru Swami from Mysore, he is asking what is the...
See, this is the pterygoid component here. This is the tumor.
Yes.
This is the infratemporal fossa, which is empty now.
Yeah.
This is your temporalis muscle. You can see laterally.
Yeah.
This is temporalis. This tumor we have removed from 2 centimeters below, pulled out everything.
Yeah.
Little bit of the, this little bit of the pterygoid venous thing, hardly
Oozing.
anything, hardly anything. You just pack I will leave a cervical control. We have already clipped the vessel distally, further distally after removal of the tumor. See, this is infratemporal fossa. See this.
Yeah.
This is your can you see?
Yes.
This
Yes.
Yeah.
This is your lateral pterygoid plate. See everyone?
Yeah.
This is pterygoid plate. This is lateral pterygoid plate. This is pterygoid fossa containing the tumor.
Yeah.
Now lateral to this is all musculature. See this?
Yes.
Yes.
Where the tumor was occupying and we have pulled out completely. See this?
Yeah.
Only muscles, nothing else.
Yeah.
So this, I'm leaving this gauge for a while. Now we have an
Yeah.
important. This entire pterygoid is involved in the tumor.
So that is to be resected, and these are the potential areas. If we even leave a smallest part of the tumor, then it is a chance of again coming back.
See now, yes, exactly, sir. Now the tumor is left over. In the pterygoid process, pterygoid fossa, this is going to the inferior orbital fissure. See there up. This is superior orbital fissure and posteriorly it continues with the cavernous sinus. So one by one we will remove this thoroughly. First of all, let me open the pterygoid fossa. See this under.
Yes.
I am removing this bone. See the tumor inside.
Yes.
See the tumor inside the pterygoid fossa. How did I know? From the
From
scan.
our scan.
Tumor is occupying the pterygoid fossa. The bone on the surface was looking normal.
Yes.
And see, now what I will do, one by one, see my tumor? Can
Yes.
you see
Yes.
the V2?
Yeah. Excellent.
See my tumor?
Yeah.
Section lagao. Yes. Look. Yes. Yes. See what I am pulling. Section lagao. Yes.
Yes.
See, I am pulling from the superior orbital fissure. That's the component which is coming. So, come on. See carefully. That's a very important part.
Yes.
See where it is coming from? Superior orbital fissure, which is in continuity from the cavernous sinus. Can you see this?
Yes.
Where this tumor has come from?
Yeah.
Behind is the cavernous carotid where my suction is.
Yeah.
See the space.
Yes.
from where the tumor has come out. That is the superior orbital fissure and the component which was pressed in the cavernous sinus. See that?
Yeah.
This venous oozing is expected. And
Yes.
see, upar bhi karna. See my V2 laterally, that is going in the foramen rotundum. Somebody was asking, this is the foramen
Yeah.
here. Okay.
Yes, perfect.
Now I will suggest. Yeah, I will remove that.
The
Yes,
pull has
yes.
to be very gentle, Dr. Satish. Otherwise,
Very gentle, very controlled. Correct.
because if you break up, then it is a bit more tedious to take it out, that small part.
Yeah, and never pack hard with the Surgicel. You
Yeah.
know, the nerves are in this. You never advocate packing hard in this region.
Yeah.
This all venous bleeding, a little bit,
Yeah.
which will control anyway. अच्छा surgical break. अरे यार. See, I'm looking for a small piece of Surgicel.
Mhm.
Yes, this was push कर. Now with the gauge. Section गया. Section gauge. See this? This is a very important part.
Yes.
We could easily pull it.
Yes.
I told you, see the lateral component came out so easily.
Yes.
The skull base component came out so easily. What all these extensions which are frightening you, believe me, are not difficult to remove. Now the pterygoid component, the huge pterygoid component, see the tumor
Yeah.
there.
Yes.
See, in the cancellous bone, see the bone underneath.
Yeah.
See how it comes out. It has to be a pulled, point out. I'll tell you how to pull. It should be a controlled pull. Let the bleeding come. Don't pack so easily.
Yeah.
Because we don't want to pack the tumor.
Yes.
All that. Yeah. Just to show you. Yes. Pterygoid bone.
Yeah.
See the tumor?
Yes.
Don't break it.
Yeah.
See this. It should come out intact. Can you see?
Yes,
Yes. Yes.
And
Very
see the
nice case.
honeycomb bone.
Yeah.
See the free bone, honeycomb bone.
Yeah.
That is how a pull is. A controlled pull to selectively remove the tumor without breaking it. Could you see the movement?
Yes.
How it was pulled?
Yes.
That's a very, controlled movement. The way this is all the remnant tumor part. See the tumor bag
Yeah.
within the pterygoid fossa. Debrider. To me, the tumor has been completely removed.
Right.
Now, this honeycomb bone, I told you, when you remove the tumor from the pterygoid fossa, it has to be a controlled one. Secondly,
Yes.
it's press with gauze or anything. If you press with anything, you can press the tumor inside.
Yeah.
So always allow the bleeding to come out. This is healthy bleeding coming from the pterygoid. See that?
Yes.
See this healthy bleeding? This won't allow the tumor to.
Yeah.
That's the pterygoid fossa. This honeycomb bone now, I am completely going to destroy it.
Yes.
The reason being, this could be a potential source of so-called recurrence. To me, the tumor has been completely removed. Now, give me the blood. Now I'm not using the previous course diamond burr. Now I'm using a different burr. You see, this is a pure a bigger diamond burr to flush it completely. See this bone, how it is being removed.
Yeah.
This is dealing with a very good process to make sure that no tumor is left behind. See this?
Dr. Satish, if you don't have the specialized burr, can you use the diamond burr, fine diamond burr?
Yes, you can.
Yeah. But it has to be more controlled.
Yes. Now, somebody was asking about the median. Now,
Yes.
see here. This is your median canal. This one.
Right.
This one here. Publicator. See, this is how you have to fill out the pterygoid.
Yeah.
You have to flush the entire bone, not leaving any space there. Yeah.
So Dr. Balakrishnan from Manipal, you have seen both foramen rotundum as well as the median canal.
Yes. And I have drilled this median canal. See my median nerve is there.
Yeah.
Now see the bone.
Yeah.
Why I'm flushing this bone? I want to ensure that not even a microscopic residue left behind.
Left behind.
Yeah. Publicator. Now first of all from below, see that this is pterygoid muscles below.
Yeah.
This is pterygoid muscles. And what you see is this venous bleeding from the pterygoid plexus. Can you see here?
Yes.
That is easily controlled with the Surgicel. Give me a small piece of Surgicel.
Satish, Dr. Udhav requested to show palatovaginal canal in relation to median canal.
Yeah, palatovaginal canal is inferomedial to it, somewhere here, which probably we have, destroyed now.
They are destroyed.
Now give me the drill further to remove. See this entire bone. Can you
Yeah.
see better? No tumor
Yes.
anywhere?
Yes. 100. Yeah.
And show further. This is something you cannot do or don't do in open approaches.
Just not possible.
Yes. Publicator. This is all venous bleeding, healthy bleeding.
Yeah.
See, this is pterygoid fossa from below.
Yeah.
Now I will show you all this anatomy in one go.
Yeah.
Remove all packs in spite of little bit of the oozing. You section that. Now see one by one to all areas. See they are up. This is onodi cell and the optic nerve above. Can you see above there? This one.
Yes.
This is your sphenoid sinus. Can you see? Okay.
Yes.
Now this is your pterygoid base. See there.
Yeah.
See this is pterygoid base. Absolutely clear.
Yeah.
Pterygoid fossa. See the bone. Completely. All honeycomb bone drilled of the sphenoid sinus. That is onodi above.
Yeah.
Now coming laterally. See this is pterygoid. This
Yeah.
is the superior orbital fissure. See.
Yes.
See this is your V2 going below.
Yeah.
V2 is just lateral to the section here.
Mm-hmm.
And superior orbital fissure is just above.
Yeah.
Section करना ऊपर. Section. ऊपर कर करो. हाँ. This is your section करो ऊपर. Yeah, this is your superior orbital fissure.
Yeah.
See that?
Yeah, it's clear.
Below is the V2.
Yeah.
This is your superior orbital fissure. Below is the V2. Now, here laterally. This is your infratemporal fossa.
Yeah.
Now, give me one by one. See everywhere, no tumor.
Yeah.
See the huge infratemporal component.
Yeah.
We have removed. So now, one by one, this is the Sergi cell or the
Yeah.
soft tissue bleeding coming from the infratemporal fossa. See that? Just press with the Sergi cell, we'll remove this gauge.
Yes.
One. This is your pterygoid fossa and the
Fossa.
pterygoid process.
Yes.
One. Press with the
Gauge piece.
yes. One small. This is for the superior orbital fissure.
Yeah.
Small gauge. Small gauge. See that?
Yeah.
Give me a gauge piece. For the nasopharynx to see.
Yeah.
So now, what? Yes, see this oozer from the nasopharyngeal surface. Give me
Yeah.
goblet. This is just above the eustachian tube. See the eustachian tube below? See the nasopharynx pretty clear.
Yeah.
The final touch going on.
Yeah. Yeah.
Yes. Yes, just a minute. Yeah. Yes. Oh. See the bleeding from the bony surface, you know,
Yeah.
or you could use a diamond, dry
Yes.
diamond, like we use in otology. See now all surfaces.
Yeah.
This is again for your information. That is onodi. See above.
Yeah.
This is sphenoid sinus.
Yeah.
This is your pterygoid complex.
Yes.
See my Sergi cell in the supraorbital fissure.
Yeah.
And now
Satish, again, Dr. Uday is asking, should you drill pterygoid plate as a precautionary case in all cases, or
yeah,
based
depending
on
upon
your-
the radiology.
right, depending on the radiology?
See now.
Yeah.
This is your infratemporal fossa.
Yeah.
With my Sergi cell in place. Can you see?
Yes. Yes.
Pterygoid with the Sergi cell in place.
Yeah.
Sphenoid, onodi,
Yeah.
supraorbital fissure, everywhere.
Yeah.
Give me a small Sergi cell more. So you can ensure, see this panoramic view.
Yeah.
Yeah.
Full panoramic view to see all area. That's the beauty of endoscopy. Not only intraoperatively, but postoperatively as well. You don't need to go for the radiology unnecessarily. See now the
True.
nasopharynx.
Yes.
See the adenoid surface, which is always free.
Yeah.
Later. Adenoid surface is always free. No bleeding at all.
Yeah.
Excellent view.
Good job. Now, precautionary, I have already done. See now what I am doing? Coagulating the naropharyngeal roof periosteum.
Yeah.
See all extensions of the tumor.
Yeah.
All the anatomy. See the pterygoid process. See how it is cleared up.
Yeah.
Only flat bone all around. See this flat bone?
Yes. Yes.
If I drill this flat bone, the temporal lobe is there up.
Yeah.
Up there is temporal lobe. From there only it enters into the middle canal fossa.
Yes.
Same way you have to pull it. That's it.
Excellent.
This is how you can remove the juvenile nasopharyngeal angiofibroma. And we have not transfused yet any bleeding, any blood.
Yeah.
See that?
Yeah.
Just we will give it a
Beautifully demonstration.
Yes.
And beautiful cleans.
Any bleeder you can look. Any doubts? See now. But we still will pack for a day or two, and then we'll advise this patient dosing. That's
Yeah.
it. That's the final picture.
Yeah.
Yeah.
Thank you.
Any questions before we move to the Dr. Haldipur with another case?
I don't think there is any. Let me see.
See, absolute hemostasis.
Yeah.
You haven't transfused any blood.
Yeah.
See, all extensions.
Yeah. Yeah.
So that's the approach. Thank you very much for your attention. Thank you. Thank you once again.
Excellent, Satish.
Yeah.
It was a treat to watch such an extensive surgery being done,
Add kar delo.
which looked so simple in your hand.
I know it. See, this is anybody can do is doing endoscopic work.
Yeah.
We have to follow the principles of endoscopic surgery. And in JNA, we have to follow all principles of exposure and taking vascularity and control, use of coagulator.
Yeah. And we should respect all the landmarks before destroying them, any of them. And then we should first deliver the tumor and then take care of the other areas.
Yes, yes.
Thank you very much, Dr. Satish.
Thank you. Thank you all for your